Hi, everyone. Thank you so much for joining us today for the second webinar in our five-part webinar series entitled Who Thrives in Assisted Living? Strategies for Effective Assessments Across Settings. Before we begin, my name is Zakia Grant Knight, and I am a Program Officer at the Center for Healthcare Strategies. For accessibility purposes, I'm a 36-year-old Black woman with long curly hair and glasses, and I'm wearing a black and white polka dot shirt. This webinar series is made possible through funding from the California Healthcare Foundation. Next slide, please. Just to go over a few housekeeping items. Please know that this webinar is being recorded and will be shared out to all registrants and posted on the CHCS website. To eliminate background noise, phone lines have been muted, and if you'd like to have closed captioning, please click the CC icon at the bottom left of your screen. If you are unfamiliar with any of the acronyms or terminology used during the webinar, we encourage you to reference the webinar acronym list available in the link in the chat. We are committed to ensuring the effective communication and equal access. If anything is inaccessible during the webinar, please send a message to hosts and panelists in the chat. Our intention is for this webinar series to be an opportunity for shared learning with all participants. That said, it is not a space for participants to try to market or sell any specific services or products. Thank you for your cooperation. Next slide, please. We encourage you all to ask questions and make comments throughout today's webinar. Once speakers' presentations have ended, there will be about 20-minute Q&A session where we'll take questions. Questions for speakers may be submitted in one of three ways. In writing, using the Q&A button at the bottom of your screen, raising your hand and asking a question verbally when called on, or 3, texting your questions to 916-862-3619 if you are listening on the phone. Questions will be answered in the order received, and you have the option to submit anonymously. We ask you to limit your questions to 1 to 2 minutes. Comments and other thoughts, including dialogue with other participants, can be placed in the chat function. We will not be monitoring the chat for questions, so questions placed there may or may not be answered. Just a note, we appreciate the wide-ranging questions we received from some of you through the registration platform. Unfortunately, we will not be able to address those questions that go beyond the main topics being addressed today. But we are taking those questions back to think about if and how we can address them either in our frequently asked questions document that will be posted to the website later this week or in a future session. Next slide, please. Next slide, please. We are going to start with an introduction of the team hosting this virtual learning series and a welcome from Kate Myers, a Senior Program Officer from the California Healthcare Foundation, the sponsor for the series. In addition to myself and Kate, our project team for this series includes Sarah Triano, Emma Rauscher, Torshira Moffett, and Meryl Schroman with the Center for Healthcare Strategies. Kate, I'll turn it to you.
Thanks very much, Zakia, and welcome everyone. I'm Kate Myers. I'm a Senior Program Officer at the California Healthcare Foundation, and I just wanted to thank you all for coming. I'm really excited that CHCF is supporting this series, working with the team at the Center for Healthcare Strategies, and really excited for today's topic because we know that there's a lot of confusion and a lot of uncertainty about which kinds of Medi-Cal members may be most appropriate for care in assisted living settings. And today's webinar, as Zakia will introduce in a minute, will be talking a little bit about that assessment process and how to think about fit for people entering assisted living. But really happy to be here today, and thank you all for coming. Back to you, Zakia.
Thanks, Kate. The goal of this learning series is to explore opportunities to strengthen cross-sector partnerships to improve appropriate, timely, and effective use of assisted living communities for people with Medi-Cal and functional needs, with key populations including older adults and people with disabilities, people with behavioral health needs, and people experiencing homelessness. There are a wide range of stakeholders attending this series, including Medi-Cal payers, enhanced care management and community support providers, assisted living operators and providers, healthcare providers, care coordination agencies, health and social services agencies, and community-based organizations, among others. We hope these webinars will foster cross-sector conversations and relationships to serve as a basis for continuing this work in your own communities. Again, feel free to connect with each other with appropriate use of the chat or during the Q&A portion. We've structured the webinar series to explore barriers and opportunities at different phases of a person's journey through the continuum of care and into assisted living. Next slide, please. During the first webinar in May, participants learned what assisted living is. And just as a reminder, for the purposes of this webinar series, the term assisted living refers to both residential care facilities for the elderly, RCFEs, and adult residential facilities, ARFs or ARFs. Participants also learned at a very high level about some of the Medi-Cal and non-Medi-Cal financing mechanisms for assisted living and heard from a panel of experts about some of the more general barriers and opportunities to serving more Medi-Cal enrollees in assisted living settings. Today, we're going to focus on some of the barriers and opportunities during the second part of the Medi-Cal enrollee's journey through the continuum of care and into assisted living. And that really starts with assessing whether assisted living is a good fit for someone or not. Future webinars and series will take us through the next phases of the journey, including barriers and opportunities during referral and placement into assisted living, supports while living in an assisted living community, and post-assisted living options. Next slide, please. By the end of the webinar today, we hope you have a better understanding of the various points at which assessments can be used to facilitate transitions to assisted living instead of more institutional settings. Learn about some of the key concerns and challenges key stakeholders have in assessing individuals for assisted living, gain a better understanding of an effective assisted living assessment model, and as always, engage in cross-sector discussions and identify opportunities for further collaboration. Next slide, please. Here's our agenda for today's webinar. I will start by providing a brief overview of what typically happens when a Medi-Cal enrollee experiences some kind of decline in physical or mental health that requires assistance with activities of daily living, ADLs. I will also talk about places where strategic involvement of Medi-Cal managed care plans and assisted living facility transition community support providers can help change that outcome where appropriate, and go over some of the basics about eligibility and assessments for the assisted living waiver and community support. Following that, I will highlight some of the key challenges identifying and assessing individuals for assisted living that the Center for Healthcare Strategies heard during the series of key informant interviews we conducted over the last few months. Then I will turn it over to our guests, Amy Scribner and Dustin Harper, to share how the Health Plan of San Mateo and Institute on Aging have been partnering to overcome some of those barriers on implementing a successful assisted living assessment model. Next, Ed Ortiz will share some insights on assessing individuals with behavioral health disabilities for assisted living based on his extensive experience. And then Health Plan of San Mateo will discuss their new and innovative Behavioral Health and Recovery Services Assisted Living pilot. That will be followed by facilitated question and answer, and then we'll wrap up and share more about the next webinar in the series coming July. Next slide, please. This slide is a graphic representation of what pathways are typically currently available. And as a note, these pathways are just examples and are not meant to be comprehensive or representative of all pathways. What typically happens today is a person experiences some kind of decline in physical or mental health and now needs help doing certain things like getting out of bed, bathing, dressing, grooming, cooking, or cleaning. Or they already received the help in the community but had a significant health event and now require it at a higher level. For some facilities or community-based providers, the level of assistance is beyond what they feel they can provide. Or sometimes there is abuse or law enforcement involvement, and the person ends up in a hospital or carceral setting. Even if the person wants to remain in the community and appears to be appropriate for assisted living, part of what hospital discharge planners and social workers have to assess is what kind of financial resources the person has to pay for board and care in an assisted living community. If the personal, financial, if they have the personal, financial, or family means to pay for themselves, they go straight to assisted living. If, however, like most Medi-Cal enrollees, they don't have the financial means to pay the average $6,250 a month it costs for assisted living, then hospital discharge planners and social workers typically look to get the person assessed and qualified for the Medi-Cal assisted living waiver. Next slide, please. To be eligible for the assisted living waiver, a person must meet basic eligibility criteria, which include they must want to and be able to live in assisted living as an alternative to institutional care. They have full scope Medi-Cal, require a nursing facility level of care, and if they are in a nursing facility, they have to have been there for 60 days or more. In addition, they have to live in 1 in 15 assisted living waiver counties, be 21 years of age or older, and be willing to go to assisted living waiver approved assisted living facility. As we mentioned during the last webinar, though, there's currently over 10,000 people on the assisted living waiver waiting list. And even if you get off the waiting list, you still have to go through a three-step assessment process with a care coordination agency before you can even apply for the assisted living waiver. What's the fastest way to get off the assisted living waiver waiting list? To be one of two priority populations for assisted living waiver eligibility, which are Adult Protective Service client, or APS, or those in a nursing facility. Next slide, please. So what's happening is skilled nursing facilities and APS are getting flooded with referrals, and people who could have been housed and received care in assisted living are instead going straight to more costly and restrictive institutional settings while they wait for an assisted living waiver spot. Next slide, please. The CalAIM Assisted Living Facility Transition Community Support, however, has the potential to disrupt and is disrupting this process and opening new and more pathways to community-based housing and care. To be eligible for the assisted living waiver, the assisted living community support, someone has to meet the same basic eligibility criteria for the assisted living waiver, which I mentioned. In addition, they have to live in one of 42 counties where the assisted living community support is offered by a Medi-Cal Managed Care Plan, or MCP, and be a member of that MCP and 18 years of age or older. But there is no wait list, and the person doesn't have to go to an assisted living waiver approved facility. There are two allowable assessments covered by the assisted living community support, and that are assessing a person's housing needs and assessing their service needs. Next slide, please. By doing these assessments at key points on a person's journey, health plans and their enhanced care management and community support providers have tremendous potential to transition and divert hundreds of Medi-Cal enrollees into assisted living settings, if not more. And in just a minute, you'll hear from one health plan that is doing just that. Next slide. Before we get to that, though, we wanted to share some of the key concerns and challenges with the current assessment process for the assisted living waiver and assisted living community support that we heard during our recent interviews with assisted living operators, managed care plans, and associations, among others. When assessing whether assisted living is a good fit for someone, some of the main concerns for Medi-Cal enrollees, their families, and community-based organizations serving them included: can the assisted living facility meet the enrollee's needs? Can the enrollee or their family afford the rent? And where or how do enrollees and their families start? We heard from enrollees that people are tired of being assessed so many times and asked the same questions at so many different places. Some of the main assisted living operator concerns included not having enough information to determine if it's a good fit until after a person is already placed, particularly with the assisted living waiver. And then sometimes the external assessments not accurately capturing the full extent of a person's needs and resulting in a mismatch between their needs and the services that are available. We heard the potential cost of the operator and the person or the family if it's not a good fit is also a potential concern, and a lack of role clarity in the assisted living community support assessment process, where some managed care plans expect assisted living operators to figure out who should go into assisted living rather than having the managed care plan identify which of their members are a good fit. Some of the main concerns we heard from managed care plans and associations included whether assessments could truly determine if housing and care and assisted living is the most cost-effective option, particularly when there's such wide variability in assisted living facility assessments, and how to assess the network level assisted living provider consensus and availability, since there is currently no way to do that without a lot of manual labor. And as Justice and Aging has documented, one of the main concerns with the assessment process for the assisted living waiver is that there is no definition of what a good fit is, leaving it up to care coordination agencies to determine whether an individual proceeds with the assisted living waiver application based on subjective criteria, which can be prone to implicit bias. Next slide, please. I will now turn it over to our first speaker for today, Amy Scribner, the Chief Health Officer at the Health Plan of San Mateo, who will talk about the health plan's process for assessing whether assisted living is a good fit for their members. Dustin Harper, the Chief Strategy Officer at the Institute on Aging, will follow Amy and talk about their important role hubs can play in the process. Ed Ortiz, a consultant at Cruz Consulting Partners, will share some insights from his extensive experience working with assisted living operators to assess individuals with behavioral health conditions for assisted living. And then Amy will round it out by sharing about the Health Plan of San Mateo's new innovative assisted living pilot for members with behavioral health conditions. All right, I'll now turn it to you, Amy.
Great, thanks, Zakia. So as Zakia mentioned, my name is Amy Scribner. I'm the Chief Health Officer at the Health Plan of San Mateo. For those who don't know the Health Plan of San Mateo, we're a local Medi-Cal and duals managed care plan in San Mateo County. Next slide, please. Great, thank you. So as many of you are aware, in California, we have two options for Medi-Cal members transitioning to an assisted living facility or residential care for the elderly, RCFE. The first is the enhanced care management benefit with nursing facility transitions, and the second is the community support of assisted living transitions. In most cases, members need both services to ensure their needs are met, both before transitioning and following the transition for sustainability. So this slide here is focused on the community support side of the assisted living transitions, which are designed to utilize those RCFE and adult residential facility, or ARF, levels of care for community maintenance. These services are authorized by managed care plans like us, the Health Plan of San Mateo, and managed care plans can either contract directly with those RCFEs or utilize a hub model in which the provider contracts with the individual facilities. Next slide, please. Super, thanks. These transitions wouldn't be possible without close collaboration between multiple organizations. So as you can see in this slide, there are three key partners that have collaborative responsibilities. The first is the skilled nursing facilities, who in our case identify members and collaborate through the discharge process. The enhanced care management or community supports provider, or what we call a hybrid provider of both enhanced care management and community supports, who do the outreach to the facilities. They help submit the referrals and authorizations to the managed care plan. They assign a care manager and find the RCFE match. And then managed care plans like Health Plan of San Mateo. And we collaborate with both of those two providers who are in our network. We oversee the contractual relationship with both. We will often jump in and help with problem solving, quality monitoring. We help support the discharge planning process, especially if it takes a while. And then our team reviews the authorization requests. Without this collaboration, none of this would be possible. Next slide, please. So now I'm going to switch over to our assessment process. This is a screenshot of what we call our community placement readiness screening form. We often refer to it as our checklist, our discharge checklist. It's a PDF document that all of our skilled nursing facilities have. It's fillable and it is submitted to us as the managed care plan with the authorization request. This is the primary screening tool that we utilize. This readiness assessment looks at lots of things, and many of the things that Zakia talked about: interest in residing in or transitioning to the community, ability for community living. It looks at things like activities of daily living, instrumental activities of daily living, willingness to accept services, and cognitive ability. As you can see here, there are both checkboxes and a comment section. This really aids in the initial assessment for services. Next slide, please. Great. This is a very busy slide, so I'm going to talk about, it's a process slide, as you can see, with various different organizations noted here. And I will talk through the highlights of this, but feel free to look back at these slides if you want a little bit more detail. So I'm going to talk through screening, authorization, and from a service delivery perspective. So the partner, as I talked about in my last slide, the partnership between the skilled nursing facility, the community supports and ECM provider, and Health Plan of San Mateo is crucial for this process to work. On this, you can see we have our primary provider, the Institute on Aging, listed here. You'll hear more from Dustin in a few minutes about what that process looks like once it gets over to them. In this model that we utilize, the skilled nursing facility does the screening, and they complete the readiness screening form for us. Then they review that readiness form with both the Institute on Aging and the Health Plan of San Mateo collaboratively, in order for us all to agree that this is the right placement for people. So following that review, the Institute on Aging or one of our other ECM and community supports providers submit the authorization form to the Health Plan of San Mateo. along with that checklist that I showed before for review. The authorization is then reviewed by our inpatient nursing team, and then an authorization or denial decision is made. From there, notifications go out to both the member and the ECM or community supports provider of assignment, and then they begin their assessment process. Next slide, please. So this slide just talks a little bit more about that process on the managed care side for reviews. So our internal team reviews for medical necessity, making sure a member is eligible and meets criteria for the level of care placement. These reviews are processed quickly. And because of that initial screening and collaborative process on the front end, we actually approved the majority of these authorization requests. However, if someone is not authorized, our internal team at the Health Plan of San Mateo works with the facility and can make a referral over to our integrated care management team at the health plan to explore different alternatives. So as I mentioned in my last slide, then we send it over to the enhanced care management and community supports provider. So now I'm going to turn it over to Dustin Harper at the Institute on Aging to talk about this next step in the process once they receive the referral.
Thank you, Amy. I'm Dustin Harper. I'm the Chief Strategy Officer, Institute on Aging, and I'm a white male with glasses and more hair on my beard than on my top of my head, I'm afraid. But thank you to CHCS folks for organizing this today. For folks that don't know Institute on Aging, we're a nonprofit based in the Bay Area, but doing work across the state, primarily focused on creating home and community-based alternatives to institutional care. So for us, assisted living's long been kind of a core element of need. And, you know, at the end of the day, I think if one thing is clear from this webinar, we collectively as a system have made accessing assisted living services for folks on Medi-Cal quite complicated. And so I think part of IOA's interest and mission around this is just to simplify and increase access to assisted living services for folks that need it. Next slide. So we're a CalAIM service provider, as Amy mentioned. We're both an ECM provider. You can see the populations of focus that we work with, and we do some of the community supports work, including the assisted living. We are accredited NCQA, and I think that's an important part of our CalAIM ECM and community supports standard of care. Next slide. I mentioned we're doing work in various parts of the state. We're going to talk a little bit about our partnership with Health Plan of San Mateo, which is where we've been doing assisted living work for a long time, but we are supporting the assisted living community support in multiple other counties. And some of these other counties we're just doing enhanced care management, but might be doing community support work soon. Next slide. So we sit in this role as a assisted living network lead entity. And for us, what that tends to mean is we act as kind of a liaison between the assisted living facilities that are interested in supporting Medi-Cal beneficiaries, but maybe are a little apprehensive or need a little extra support to participate. Some of them have participated with the assisted living waiver. Some of them haven't. Some of them have had good experiences participating with the assisted living waiver. Some of them haven't. You can also see we try and leverage the assisted living waiver as best we can, but as was mentioned earlier, there is quite a lengthy wait list right now, and the regional gap in access around assisted living waiver is one of the fundamental flaws in our system right now. So I am most hopeful that the community supports around assisted living will make a more equitable access to assisted living across the state. For the liaisoning with the managed care organizations, you know, I think for this, assisted living and that community support is a really important community support for the managed cares, especially as they look at their long-term care population. But it also requires a significant amount of providers to participate and to try and match members' needs and preferences with a good fit. It's not really sufficient for a managed care organization to contract with 1 or 2 assisted living facilities. So having an entity like IOA act as a network lead helps expand the opportunity of choices. It helps expand trying to find cultural fit, neighborhood fit. It really, we think, broadens the array of possibilities for folks and leads to more likely success with folks' placements. One of the roles that we also try and play is the enhanced care management entity. As within the enhanced care management benefit, all of the services included in that, but with a particular focus on making sure that folks are getting what they need at the assisted living facility, and that the assisted living facility is getting the support in any additional care or services or supports that individual might need. So we do feel like having that kind of enhanced care management component there helps increase the likelihood of success while someone's there. And then, it's come up a little bit already here, but the timeliness of access to assisted living. The folks in skilled nursing facilities or in post-acute care need assisted living placement. It's just not very realistic or plausible to wait for 6-12 months on a waiting list before that service is available. So the community supports and working with our managed care partners and the process that Amy outlined there allows us to move at the speed that the healthcare system and our health plan partners need and want to be able to get folks to the right level of care when they need it. So that timeliness of access is both an important component here, but also really one of those defining features around a high functioning home and community-based system of care. So we try and make sure that we can move quickly there. Next slide. And I'll just say a couple more things around why we feel like this matters. I think Zakiya showed a continuum of care slide there that really it highlighted the gap between independent living in the community and skilled nursing facility, especially for folks with cognitive decline or who are just kind of starting to need some additional levels of support in the community. There's such a wide gap between what their experience of living day to day is in an assisted living, a small assisted living setting compared to a large institutional skilled nursing facility. So it's really an essential step for folks on that aging journey, and for a health plan or anyone who's looking at kind of a long-term care utilization management strategy. It's really seems foolish to not have a functioning intermediate step there. I talked a little bit around how we see the network lead entity both taking some of the administrative burden of this community support off of the managed care organizations, but also trying to keep the assisted living facilities connected and having a good experience as well. For most assisted living facilities, they're not trying to serve exclusively the Medi-Cal population. So it's important for them to feel like they've got a partner and a liaison that they can rely on for regular referrals, but also support when they need it. And then finally, just this lack of access for members in need right now feels like such a fundamental gap for us. So I'm grateful for healthcare strategies and other folks working on this issue, trying to raise awareness, and hopeful that the community supports will help close that gap. But my friend Ed Ortiz will help shed light on some of the other initiatives around this, and appreciate the time.
Thank you, Dustin. Just to start out, for accessibility purposes, I'm a male, late 50s. I'm wearing a light blue shirt and glasses, and like Dustin, I probably have more hair on my chin than I do on my head. Just in terms of professional introductions, I was previously the Chief Network Officer at a health plan, but for the last 8 years, I've been a project consultant working primarily in behavioral health and what I call CalAIM optimization, working with managed care plans, foundations, community-based organizations, doing a lot of work right now in community hubs. So, good morning, everyone. I want to begin by sharing where I'm coming from in this conversation. I'm not a clinician. My background is in managed care. I previously served as a chief network officer for a health plan. And throughout my career in healthcare, I focused on how to build care ecosystems that function. So connecting services across silos so people don't get lost in the system. So when I look at housing placements for individuals with behavioral health needs, I see it through the lens of structure and system design. How do we ensure assessments, referrals, service capabilities align to create the right match? What you see on this first slide summarizes the ways in which the current assessment and placement system is both highly variable and misaligned, particularly for adult residential facilities and residential care facilities for the elderly, which I will just refer to as ARFs and RCFEs going forward, how they serve people with behavioral health conditions. You'll see this slide is really just an example of Los Angeles County. And this slide really reflects potentially 10 different organizations that would be organizing some sort of assessment tool process. So the issues that we face come directly from the field. Operators and referring partners report major breakdowns, assessments that rely on clinical language that doesn't translate to daily care needs, behavioral health or substance use histories that are absent or incomplete, and operational realities like roommate compatibility, supervision triggers, or risk of unsupervised exits that are simply not captured. Even when assessments are done well, they're not always shared across referring agencies or managed care plans, which results in duplicate effort or conflicting information. And critically, reimbursement doesn't always follow need. A person may be assessed with complex behavioral health requirements, but there's often no corresponding mechanism to adjust payment or ensure additional support. The cost of this misalignment is real. We see all too often a placement resulting in an ARF or an RCFE selection error. A most recent study conducted by the Future Organization in 2023 that focused on LA County does a really nice job of highlighting sort of this selection error between ARFs and RCFEs and the rate of transfer. And a large part, this is due to poor placement match in the first place. So let's zoom in a little bit on the operator's perspective. And if you'll advance to the next slide, this slide reflects themes collected directly from residential care providers, many of whom are being asked to take on more behavioral complexity than ever before with less and less support. First, the language mismatch. Assessments often use terms that don't connect to the operator's practical concerns. The operator needs to know, does this person wander? Have they been aggressive? Can they self-initiate hygiene? These are functional questions, not diagnostic codes. Second, behavioral health and substance use disorders are often underdocumented or missing altogether. A person may have a history of psychiatric hospitalization or a substance use remission plan that's never referenced, leaving the operator unprepared to support them. And other placement factors like eviction, roommate history, and supervision needs are inconsistently captured. These aren't extra details. They determine whether a placement works or breaks down. And finally, reimbursement frequently fails to reflect actual acuity. Facilities taking higher need clients often do so without any enhanced payment or staffing support, which isn't sustainable. So we've seen how these gaps play out in practice. And if you will advance to the next slide, on this slide, I've included a couple of examples. For now, I'll just focus on one on this slide to illustrate the point, and I'll be focusing on example number 2. These examples highlight how additional information might improve the chances for an appropriate placement. I'll be adding a little bit more of extended information into the example, but for the purposes of this, a client stabilized in an inpatient psychiatric facility and ready for discharge, but kept getting declined by our providers. The assessment noted a history of psychosis and intermittent nonverbal behavior, but failed to mention that the client was easily redirected, had no recent aggression, and was actively engaged with outpatient care. Without that context, the individual was perceived as too high risk. The result, weeks of unnecessary inpatient days and system churn. A more complete, behaviorally informed assessment could have changed that outcome. As you review the other case here, I invite you to just think about what might be missing when an assessment is created for case number one, and what the referring team or the system could do to improve the match for that placement. Now, if you will continue to the next slide, I'll go through one more example just to make the point again. This slide continues the theme with another example. And again, I'll focus just on one case, though the other raises equally important challenges. In this scenario, I'm looking at number 3, a person in interim housing was medically stable but showing signs of cognitive decline, poor impulse control, and paranoia. The referring team recommended a boarding care setting, an ARF, an RCFE, but the assessment lacked information about behavioral triggers, past psychiatric admission, or the need for enhanced supervision. The placement quickly broke down, resulting in a discharge within 2 weeks and a return to crisis services. As with the previous slide, I encourage you to think about the underlying assessment and referral processes that might have prevented better outcomes in these examples. I think in closing, the key takeaway really is that assessment is infrastructure. If we get it wrong at the front end, everything downstream, whether it's placement, care planning, and stability, suffers. And this isn't just a design flaw in this process. It's really a shared responsibility under policy. So managed care plans under the all plan letter and mental health plans, behavioral health plans under behavioral health information notices are required to coordinate for shared members. And that includes collaboration around community supports like ARFs and RCFEs, and alignment on assessments that inform these types of placements. The great news is we have policy alignment across systems, we have shared goals, and we have committed partners. If we work together, plans and counties, providers and operators, we can reduce inappropriate placements, we can build shared accountability to support placements once placed, and design a care ecosystem where ARFs and RCFEs are true assets in the behavioral health continuum. So I appreciate the opportunity to share this information and my perspective, and I will turn it back to Amy Scribner.
Thanks, Ben. And apologies, I did not do this at the beginning. Amy Scribner, Chief Health Officer at Health Plan of San Mateo. I'm a middle-aged white woman. I'm wearing glasses and I have long brown hair. Next slide, please. So what I'm going to talk about is what we think is a unique pilot that we are working to launch in San Mateo County. So as you have heard from others in this webinar, access to RCFEs can be challenging, both on the assisted living waiver and also from a capacity perspective and community supports. Ed talked a little bit about some of the unique challenges on the behavioral health side. And so this is kind of the melding of some of those, trying to address some of those pieces. So in San Mateo County, we have been facing a challenge of RCFEs closing. A number of the RCFEs here in San Mateo County are family owned and operated. Many of these are smaller 6-bed RCFEs. In recent years, a number of those owners and operators have decided to retire and don't have a succession plan. Given the housing prices are extremely high in San Mateo County, these owner operators are often making decisions of selling the home to generate a significant profit so that they can retire. As a result, people are being displaced from our CFEs and needing to move to new facilities, which, as we all know, can be very disruptive to residents and families. So as a result of this, we have always had a strong partnership with our county mental health plan, behavioral health and recovery services. We are a county organized health system. And with the addition of CalAIM dollars and some additional capital dollars in the county's budget, we have partnered and collectively decided to create a pilot to try to support our CFEs. Next slide, please. Oops, I think, yeah, perfect, great. So for the pilot, we agreed to leverage each organization's strengths. So as I discussed earlier, we have the CalAIM services of enhanced care management and community supports through us as Health Plan of San Mateo. And then we are able to blend that with traditional managed care services like medical services. And in San Mateo, the Health Plan of San Mateo also has a pilot for dental services. So we provide all of the dental services for our members, and those are integrated within our plan. On the mental health plan side, behavioral health and recovery services, we're able to, through county dollars, utilize some capital for property purchase. And then obviously they are experts on both traditional and novel psychiatric services. So we came to this decision that blending and braiding this funding has really allowed us to think creatively to help meet the unique needs of the behavioral health population here in San Mateo County. Next slide, please. Great. So we are still early in this process of the pilot, but what we have done so far is really dug in on eligibility, assessment, services, and the facility to maximize positive impact and hopefully create some sustainability. So as I mentioned in my last slide, we really focused on what this population needs and then moved in to how we can leverage each organization's strengths and expertise. As Ed mentioned in our CFEs, those with significant mental health symptoms or in a step down from an IMD or an inpatient psychiatric unit, getting to services can be really challenging. The needs are really high. So we really decided to partner to provide additional enhanced services on site. And so you can see some of those here, but those really include in the services offered on site, the psychiatric care therapy through the behavioral health and recovery services mental health plan, primary care and field medicine through the Health Plan of San Mateo. Mobile labs will be kind of shared by both systems. Transportation is a benefit under managed care, so the Health Plan of San Mateo. We are currently in discussion on specialty provider types. It may be Health Plan of San Mateo, it may be shared depending on the type of services. The caregiving services, meals, and care management. So we have both ECM and community supports, but we're really working with providers with the operator to determine what the right caregiver to resident ratios are to be able to manage this population. And then behavioral health and recovery services has some building maintenance, upkeep, and insurance. This is really going to be a pilot. So we are in the phases of what we think we need in order for this to be successful. It will be an iterative process in which we'll continue to add or adjust services as needs arise. Next slide, please. Great. So just to give you a little bit, I know I said we're early in the journey. We've been planning for what seems like a long time, and sometimes being in it can feel like, okay, we're ready to just launch now, but there is a lot of work that goes on here to get to hopefully where we will open ideally in January of next year. So the first step was really that approval for housing search for the RCFE site in San Mateo County. Earlier this year, we started that collaborative planning for services on site and determining what eligibility criteria would look like. The county received approval for the site purchase. We worked with an RCFE operator and administrator that we had worked with historically. They came back with a pro forma and helped us with layout of facility and other considerations. The purchase is hopefully complete now, and renovations have started to ensure ADA accessibility and some other accessibility pieces that were previously there, but ensuring it's up to code. And then in September of this year, we're really hoping to make final decisions about services and providers. We have collectively talked to various providers in terms of what services can be provided on site and some of those mechanisms. From September to January, we will be making sure our contracts are up to date and our processes are tested so that these providers can really go on site and bill for the services that they're providing. And then January 2026, we are anticipating that RCFE opening. We're really excited about this pilot. We also know we have a lot of work ahead to get to that first person moving in. Now I will turn it back over to Sarah at CHCS. Thanks.
Thanks so much, Amy. Just a quick description of myself for folks who are blind or visually impaired on the webinar today. I'm a white 50-year-old woman with long, straight red hair that's going gray, proudly, I might add. I'm proud of my grays. And I have green eyes. I'm wearing a black jacket, a red shirt underneath, cheetah print and pink glasses. And I'm sitting at my desk in my home in Northern California. So that was a lot of really great information that we just threw at you. So I'm going to do my best to quickly just lift up some of the key themes from the presentation. And then I know we've got questions coming in already, so we'll get to your questions. But, you know, some of the things that I heard that I think are really important, you know, a strong partnership between the managed care plan, the skilled nursing facility, and the assisted living community support providers is absolutely essential to being successful here. And then, you know, one of the things we heard, we did a bunch of interviews for a few months, and we talked with assisted living operators. And one of the things we heard was confusion about roles during the assisted living facility transition community support implementation. And it really helps, I think, when managed care plans clearly delineate roles for all the collaborators involved, like Health Plan of San Mateo does. So everybody is clear about who's responsible for member identification and appropriateness determinations and outreach to family members. And that way the facilities don't feel like it's all placed on them. To reduce potential for bias in the assessment process, you know, Zakia mentioned that at the beginning. I think it's good to have a unified kind of definition of what a good fit is for assisted living, and tools like Health Plan of San Mateo's checklist really can help with that. And I know they're willing to share that checklist. So the health plans so far, you know, another just kind of key takeaway, the health plans so far that have the highest utilization of the assisted living community support are those that contract with an assisted living network lead entity or a hub, like the Institute on Aging. They can be, as Dustin mentioned, they can be particularly helpful for smaller family-run assisted living facilities that haven't worked with managed care before and don't really know the billing processes. They can really take off that administrative burden for the managed care plans and the assisted living operators. And that this matching process that happens, kind of the dating game, it's really critical to the success, and it's something that requires full-time attention. And if you don't have the means to be able to do that, working with the hub certainly is one of the ways to address that. And then, you know, just the last point there with Dustin's presentation, really the importance of timeliness of access to assisted living and how this community support can help with that timeliness issue so that we don't have to have that wait for the spot on the assisted living waiver facility and have folks go unnecessarily to more institutional settings. You know, Ed really shared a lot about the accurate, unbiased assessments are critical, right? Not only in transitioning or diverting people from institutional settings, but also in ensuring that successful match that we just talked about. Assessment is infrastructure. If we do it well on the front end, and it has to be a shared responsibility. It can't be like they're responsible for assessment or, you know, it's all on you. It's a shared responsibility between that partnership. Context is really critical when it comes to assessments, particularly for folks with more significant behavioral health disabilities. And you can't just look at the person's diagnosis. You have to look at the assessment with a lens of what might be missing here that won't capture some of those things. Like a lot of the typical assessments for activities of daily living, they'll ask, can the person take a shower independently? Well, if you've got an older adult who has dementia, they can take a shower independently. Will they? No, they won't. So it's really the importance of that context, I think, was an important point that Ed made. And then I will just say that something else we heard from the assisted living operators when we were interviewing them is that some of the best assessments, particularly for folks with that behavioral health needs to get that context, are done in person. So it's not just some form you fill out. Really effective assessments are done in person. And then, lastly, just coming back to that pilot that Amy just shared with you about, the exciting pilot, just as we need to kind of focus on aging in place for older adults, we also really need to focus on how we can support aging providers, a critical community-based infrastructure that helps older adults and people with disabilities remain in community settings. Creative efforts to partner and braid CalAIM dollars and services with county behavioral health dollars and services that can really meet this like funding and resource gap that currently exists and help address the needs of the folks who quite frankly just fall through the cracks because they don't fit a certain model or what have you. So especially older adults with behavioral health needs. And then the last thing that I'll just mention here is, as Ed said, it's about structure and system design. And as someone with bipolar disorder, I find the enhanced services on site that the health plan of San Mateo is going to be offering, the mobile labs, oh my gosh, that is freaking brilliant. One of the hardest things to do when you have a behavioral health disability, I can tell you from my personal experience, and you're symptomatic, is to think and plan ahead. I mean, there's some days when getting out of bed is just hard enough, let alone calculating out when and how I'm going to get to a lab to do my blood work in time so that I can request my refill. I mean, it's amazing. So kudos to Health Plan of San Mateo for really taking care of oneself easier, not just for the target population, but potentially for everybody. So thank you again to all of our speakers. And I'm going to just turn it over to Emma on our team, who's going to facilitate the question and answer session with the speakers and you. All right, Emma.
Great. Thank you so much, Sarah, and to all of our speakers. My name is Emma Rauscher. I'm a program officer at CHCS. And just for accessibility purposes, I am a white woman in my mid-20s. I'm sitting in our office right now, so I've just got a blank white wall behind me. And I have shoulder-length brown hair and kind of a gray patterned shirt on today. So I will be facilitating our Q&A session today. So thank you so much to everyone who has put questions in the chat and in the Q&A. We've been keeping note of the questions that have been submitted, so I'll go through and kind of ask those questions to our panelists in the order that they came through. You're also welcome to ask questions live. So if you have a question that you want to ask verbally, please feel free to use the raise hand function, and we'll call on you also in the order that your hands are raised. And we will invite you to come off of mute so that you can ask your question live. And just for both live questions and written questions, to make an effort to hear from as many people as possible, we're going to prioritize calling on participants who we've not heard from before. Then as time allows, we can circle back to anyone who's asked multiple or additional questions. So I will go ahead and start us off with our live questions. So if anyone has any questions that you'd like to ask verbally or live, please feel free to raise your hand and we'll invite you to come off mute. I'm not hearing any or seeing any hands come through, so I can go ahead and start us off with our first question that came through in the Q&A, which is from Andrew Suggs. And the question is, are acute rehab units discharge planners allowed to refer patients to assisted living facilities? And Andrew, we're going to invite you to come off mute if you want to add any additional context to your question at all, but feel free to decline the notification if you are okay with us reading it for you.
Inviting me to chat. I think the question is more so directed to Dustin. I'm thinking about the WIFM, the what's in it for me for the assisted living facilities to supplement their Medi-Cal patients. Have you thought about working with acute rehab units to also feed them Medicare patients to kind of supplement the Medi-Cal patients, or is this primarily focused on just the Medi-Cal patient population? Thank you.
In terms of eligible to make referrals, certainly eligible to make referrals. The benefits and the assisted living community supports are really only available to folks that are Medi-Cal beneficiaries at this point. There may be some short-term, Medicare benefits to tap into depending on the situation, but for the most part, we're talking about long-term Medi-Cal supports.
Have you thought about working with the ARUs that have the Medi-Cal patient population, or is it primarily just working with the SNFs at this point?
We're open to working with any partners that have clients in need. So with our health plan partners and working through our authorization process, we're happy to work with referral partners from all parts of the system.
Great, thanks, Dustin, and thanks, Andrew. Our next question that came through was from Julian Schrick. And I'm assuming this one's for Amy and Dustin, but Julian, again, feel free to come off mute if you want to add anything to your question that I'm about to read out. So it's, how many SNFs are part of the collaboration in San Mateo County?
Amy, I'm going to defer to you if you know your number of SNFs.
Yes, I can answer that. I didn't know Jillian wanted to ask any other parts of the question or anything.
Oh, well, hi. Yeah, I mean, it kind of goes together. I'm also just curious if you have a patch program where you pay a day rate on top of the reimbursement rate the SNF is getting and how that works for you. I'm from Alameda County, behavioral health.
Great. So I can answer the SNF side first. So pre-pandemic, we developed a SNF collaborative. Our inpatient team and our provider services team worked together to develop a SNF collaborative for all of the skilled nursing facilities and long-term care facilities in San Mateo County and some of the surrounding counties. There are about 30-ish SNFs that participate in that collaborative. It was really instrumental during COVID. It has now morphed a little bit, but those are the key groups that work very closely with our team. We have, and I think I have the actual number, we have about 112 SNFs and long-term cares that we're contracted with across the network. But this is kind of the core that gets the majority of our folks, and so they're the ones that we partner with most closely. On the patch side, once somebody transitions over on the community support side, it's both the kind of services for that transition and for sustainability in the transition. And then we actually mirror the assisted living waiver rates for the services on site. So the members pay their kind of room and board part of it, which is often SSI. And then on top of that, we place services based on the needs of the members, and we mirror the rates that are offered in the assisted living. Justin, do you want to add anything?
Thank you.
Thank you, guys. Our next question that came in is another question for HPSM, and it's from Linda Kaufman. And her question was, if we are already contracted with San Mateo County Behavioral Health Services for residential and specialty outpatient mental health services, do we need to contract separately with San Mateo Health Plan, or is there a collaborative mutual contracting ability?
That is a great question. I would say on the community support side, we don't have like specialty behavioral health assisted living facilities. But on the pilot, I think we are still determining some of the processes. And so I would say, like, please reach out. I can share my contact information, or it might be on the slides. And we'd love to talk more about that.
Thank you, Amy. Linda, yeah, we'll invite you to come off mute if there's anything else that you wanted to ask or add to that question.
Sorry. Oh, yeah, you can hear me. So thank you very much. I mean, this is all super informative. I was not aware of these pilot programs. And I can just say that as a comment, you know, for 10 years, we've been holding focus groups and advisory meetings, you know, doing all of these things about what the needs are of, you know, truly the 28 counties we do contract with. You know, received a CCE grant for $8 million, open an RCFE. It's like, wow, we're really serving some needs. And here I am sitting with 25 open beds out of the 54. So it's confusing, right? You feel like you planned everything correctly, you did everything right, and yet it's like, well, what are we not doing? So it's great that you guys are having this, because maybe a little clarity. And then I hear 10,000 on a waiting list, and it was just like, okay, that feels very overwhelming also. So I think these series are excellent. I really appreciate them. When you think you know a lot, you find out you don't. So thank you. I do appreciate all of this information.
Great. Thank you so much, Linda and Amy. And I'm going to go ahead and jump to two of the other questions that we got in the Q&A, and then I'll circle back to you, Julian, for to call on your raised hand. So our first question was from Deborah Draves, and it's also for HPSM. She's noted that San Mateo County has over 200 licensed RCFEs and over 4,000 apartments. Does HPSM only use ALW providers for the community support?
So we also do the transition to community support, and I know they just retooled that, and I'm trying to remember off the top of my head what it's called, but we use both. We have some partnerships. Sorry, I jumped in, and Deborah, you can add to it. But we have partnerships with Housing Authority and Department of Housing in San Mateo County also for new buildings that are coming on board, some project-based vouchers for low-income folks that are HPSM members. We have both family house. We're getting some family housing vouchers, hopefully in 2026, and then we have vouchers for those who are adults, and several of those, and so they kind of jump the line from an eligibility perspective on the housing vouchers as well. We do not utilize the assisted living waiver for those vouchers. I know in some places supportive housing is another place where the assisted living waiver can be used, but we've leveraged some additional partnerships that we have that do not leverage assisted living waiver for independent.
Thank you for that clarity, Amy. We don't have a contract with Health Plan of San Mateo, and so I'm not familiar with your model, but there are several other plans throughout California that restrict the community support, transition or diversion to assisted living only to assisted living waiver providers. And so when you were mentioning that there is a capacity issue, that there's a diminishing number of assisted living providers, I was curious if you're only utilizing assisted living waiver providers, or if it's open to all 200 plus and including the provider that was just ahead of me.
Just to add to this, and then I'll send it over to Dustin for some additional, because they're actually contracting with RCFEs. But I think there are 1 or 2 assisted living waiver providers in San Mateo County, so it's a very small number. So the network of RCFEs that people can get placed in through this community support through the Institute on Aging is significantly higher than those 1 or 2 facilities.
Okay.
Indeed, and I would just add, with the length of that assisted living waiver wait list and capacity issues we've been talking about, it's awfully hard to convince a provider to enroll and go through that process. So I don't think hanging on to that restriction or requirement is going to be very tenable for managed care partners.
Agree, Dustin. Yeah. I totally agree. That's been our experience as well. Thank you for that clarification, and thank you for what you're doing. It sounds very exciting from the behavioral health standpoint.
So thank you guys. Our next question in the chat was submitted anonymously, so I'm just going to read it, and then whoever submitted the question, if you'd like to come off mute, just feel free to send us a message in the chat and we can take you off. But this question is specific to the updated and expanded definition of community supports related to ALF transitions, and in particular, the ongoing personal care services. We've heard that there are contracting problems and confusion. Specifically, are managed care plans contracting directly with home health agencies or other personal care service providers to pair with an assisted living facility partner? Or are they contracting with the assisted living facility and asking them to deliver the personal care services, either directly or through subcontracts? And I just want to highlight that this topic is what we'll be focusing on in our 4th webinar in August. So we'll have a lot more detail and information during that session, but I just wanted to pose it to you all now in case you have anything to comment on.
I can say that the Health Plan of San Mateo is not currently doing that, so I look forward to your next webinar series to learn more about that.
Great. And just to clarify, Amy, do you mean that you're currently contracting with facilities directly and they're providing services as of now?
Yes. So we are contracting with the Institute on Aging, who is contracting with the facilities to provide services on site.
Yeah, I would just reiterate something Amy said earlier around, we mirror the assisted living waiver services tiering, and that's what's paying for the services at the facility. The client or member is paying their room and board themselves, oftentimes through SSI. And I can see situations where it would make sense to have a one-on-one personal caregiver coming from a different personal care services provider. So I think it's probably not the most common practice, but I think there are some instances where that would make sense.
Got it. Thank you both. Okay, I will now circle back to any questions that anyone has that you'd like to ask live. So if you want to raise your hand and be invited to come off mute, you can do that now. But Julianne, I'll start with you.
Hi, thanks. I was curious for the RCFE project in San Mateo, how many beds is that RCFE? And then I have one other quick question.
Yeah, so right now it's looking like it's going to be 8 beds. You know, one of the pieces in this that I think has been an interesting discovery is, so there are 10 beds, but one of the rooms is going to get converted into like a staff room. And then one of the So anyways, 2 beds are going to get taken out of the 10 beds because we're going to convert it into a staff room, which can also serve as an exam room, given all the services are going to be provided on site. So 8 beds. And I think one of the things that we have learned through this process is that while 8 beds is great, the economies of scale are really tricky in the smaller facilities. And so, you know, we're going to pilot it here and then look at alternatives for larger sites like 16 beds or more, because I think we will be able to create more sustainability in that.
Right, right. And then are you exploring at all working with non-licensed room and boards?
So our county behavioral health does. We have not yet we have not in the community support side.
Yeah, okay. Thank you.
I don't see any other hands raised right now, so I'm going to go back to our written questions, but feel free to raise your hand if any questions. So the first one is from Kamaljit Hire. Are there any financial or income limits to qualify for assisted living placement? And if you want to come off mute, we'll give you a second to do so.
Hi, I was just wondering if there was anything as far as the member has to have an income in order to qualify for placement in one of these facilities.
We can go on that one again. So great question. So yes, generally, because otherwise we have not gained much traction in just the kind of assisted living waiver rates. The assisted living waiver rates plus the member's income have created a package for it to be sustainable and a little bit closer to private pay rates. Additionally, as we all probably know, that on the community support side, at least, it really is intended to provide the services and not the actual like room and board part of it. So right now we do have the restriction that they have to pay a portion of their income for the room and board pieces. I don't know if Dustin, you want to add anything?
I would just point to the debates happening at the state and federal government right now around the asset limits for Medi-Cal, right? This is a big deal for folks that need assisted living services for a long period of time. What level of spend down is required to qualify for Medi-Cal? What is the process that happens to get there? Those are things that are being decided at state and federal levels right now. So it's an important time for that voice to be heard. You know, one of the things that was most intriguing to us at IOA about the removal of the asset limit for Medi-Cal was it really started to feel like a true long-term care access for anyone who needed those services. You know, clearly there's financial implications around that, and that's part of why it's been dialed back in the state and federal budget proposals. But it's a really big gap and need for folks that have this have an ongoing need for assisted living support and are just above that Medi-Cal income and asset eligibility. So big one to pay attention to.
Yeah, thank you guys for your answers and highlighting that. I also just wanted to, sorry, my light in my office keeps coming out. Just wanted to highlight also that in our 4th webinar in August, we'll be talking a little bit more about some of the financial supports that are available for people who need help paying their room and board as well. So we'll talk a little bit more about that in the future. And then we had another written question from Manjeet. I'll give a second to see if you want to come off mute. But that question was that most assisted living facilities say they only take private pay. How can we find a list of facilities that accept Medi-Cal?
I mean, I can chime in a little on this one. I know I do a lot of work in Los Angeles County, and there are lists of facilities that participate in Medi-Cal. So you could see, for example, those that participate with Department of Mental Health. They have a website that shows those facilities. There are other lists. There's the LARCA, the Licensed Adult Residential Care Association. They have a list of facilities, and many of their members participate in Medi-Cal. The assisted living waiver is Medi-Cal, and those facilities are listed in there as well. I think just the point that I wanted to make about that is that a lot of the relationships that create placement are really narrow. They're really focused on departments or different entities that connect into, for example, the justice system or the mental health systems. And this is really an opportunity for, I think, for ARF and RCFE operators to have access and participate in a wide range of Medi-Cal programs. I mean, this is Medi-Cal, so this is an opportunity to expand and really expand their access and create greater participation. That will increase the number of Medi-Cal participating operators if we can just find a way to maybe standardize some of the processes, the assessments, the referral processes, and create a reimbursement at a level that allows the facility to provide a service and to reinvest in their facility versus just survive. And I think it's just a mixed bag right now in terms of the various systems. So right now, I think a lot of the connection is with certain specific known relationships and departments for certain populations. But hopefully, as we have conversations like this, and as we see the example of Health Plan of San Mateo really bridging the physical health and the behavioral health aspects of somebody's whole care, that we'll see greater access because the market will feel like this is really an opportunity to participate. So I'll stop there, but thank you for that question.
Thank you. Sorry, I just got another call. So no, I heard your response. So this is the challenge we have. We have releasing parolees, and it's really hard to find. And then some facilities reach out to us. They say, "How will we get paid?" And so they don't know like how to work with CalAIM to get their payment for assisted living, and who can we connect them with so they can figure out the payment part.
Yeah, I mean, it's really confusing. Again, I'm doing a lot of work in LA County on this right now, and I think I counted 14 different payers for these services. So you could just imagine the complexity of trying to participate in a space where the requirements are all kind of different from each other. And on the other side of it, the operator many times is a small business. I mean, if you really think about it. So it's an opportunity clearly for in this conversation for managed care plans and for counties to collaborate. The mismatch of all of these different systems, and the other side of that is that for example in LA County there's 6,400 empty ARF and RCFE beds in facilities that would accept Medi-Cal. I mean, it's just a huge mismatch and an extremely great opportunity to make those connections and improve the outcomes. I mean, we see system flow, like just systems are clogged at every level of acuity, from skilled nursing to inpatient, and these ARFs and RCFEs create just an important opportunity to kind of create more flow and relieve some of those other higher acute kinds of placements. But thank you for that.
Thank you. And one facility really was so motivated to help us and even took some patients and then stopped taking our patients because they're not being reimbursed. So yeah, so she didn't want patients on managed care plan. She wanted them on straight Medi-Cal so she can put them on the one that is better. So I didn't understand. I'm not really good with the payment part. So they stopped taking her patients. So now I hate dropping these patients. ERs are already burdened with acute patients, and then we can't hold, releasing inmates in CDCR. We have to release them on the release date. So we have no other option other than putting them in ER because we can't just leave them on the street. So then we hear from senators, we hear from hospital management, they get really upset. So we try to make every attempt to find place. And we've been successful actually. A couple of facilities, at times they accept our patients. And there's Leisure Garden in Lancaster, there's Grand Valley, they took our patient. So there's Edgemore in San Diego. So there's few facilities. So I don't know how they figured out the payment. So they do take patients at times, very selective, but still do.
Great. Thank you so much for your questions and comments. I see a couple hands raised, so I'm gonna move to, sorry, I lost where I can view which hands are up. Julianne, I see your hand up, so we can open it up to you.
Thank you. I'm really interested in the whole assessment as infrastructure, and rather than kind of, trying to figure that out and recreate the wheel again within our system, can you point us to any specific tools or resources that are accessible around how health systems can partner around that in terms, and I'm looking at both medical and psychiatric acute to subacute, like MHRC, IMD, also from those settings to assisted living, but also to like crisis residential and also non-licensed or room and board facilities, including jail and homeless continuum of care, but we can leave those out for now. I'm just wondering, I guess the question really is like, where do you recommend starting? Because right now everyone's doing their own assessments. No one has eyes on all the assessments. Most of them are never going to get read. Some of them would be extremely helpful if everybody could see them, but the language is very diverse in terms of which professional is writing them and how they're written.
Yeah, I mean, I can start, and then I think Amy and Dustin may have some thoughts on this as well. So when I started doing some work in Los Angeles County, the first thing that I did was try to organize in my own head sort of who is referring into the ARFs and RCFEs, what kind of system actors are doing this. And so, I looked at all the managed care plans, and there's 6 of them in LA County. I looked at the Department of Mental Health. I looked at some of the programs that the county also delivers through the ODR, the Diversion Reentry Program. They have a Housing for Health where so there's a number of programs. I think, as I said, there were maybe 14 different organizations that are using, that I could count in LA County using ARFs and RCFEs. You may want to just start with the ones that you are meant to connect into based on wherever you sit in the ecosystem, and then kind of branch out a little bit. The assisted living waiver assessments, I think, are online. The LA Department of Mental Health 5x5 tool is online. Amy has a tool she's going to share. I mean, there's a bunch of tools. It's really, the question really is sort of what population are you trying to serve, and what do you think is sort of what are the best pieces of an assessment? I mean, I heard Sarah mention earlier that many operators prefer to have in-person assessments. It's a very different process than some of these other systems like the assisted living waiver, where I think it happens on Zoom. I think it's a big question, but those are some tidbits that might offer some direction.
Thank you.
Thank you, Ed. Okay, we only have a couple minutes left, and I'm not seeing any other questions coming through or any other hands raised. So I might go ahead and close this out, but if anyone has any last minute question that you want to ask, please feel free to do so now. I just want to draw attention to the link that Meryl just dropped in the chat for everyone. We are keeping a running list of all of our Q&A sessions on our website from this webinar series. So the link in the chat right now has all of the questions from our first webinar posted. And that includes ones that we answered live, as well as ones that were asked that were not able to be answered live. So you can go there if you want to see those answers. And then the plan is to do the same thing for each of the webinars in the series. So within a week of each session, we'll post all of the questions that were asked and answered live, and then answer any ones in writing that we weren't able to get to during the series. So just wanted to point that out there. And I will go ahead and turn it back to Zakia for us.
Thanks, Emma. On behalf of the Center for Healthcare Strategies, we'd like to thank all of our presenters and participants, as well as our sponsor for this series, the California Healthcare Foundation. Thank you all so much for your thoughtful questions and comments that have been shared throughout this webinar. We're grateful to all of you for your support and your interest in this series. And if you have further questions, we welcome you to send an email to myself or Emma with any questions that you have. We will also be putting our emails in the chat for you. As a reminder, we'll be sending out today's slides and recording, as well as an evaluation survey. We'd really appreciate any feedback you have to help us shape future sessions in the series and make sure we're covering the topics and questions that you want to see covered. We hope you have a great day and hope to see you in July for part 3 of our webinar series.